Hello, everyone. Wow, good afternoon or good evening. Good evening. So it's wonderful to see all of you here. And actually, as I'm looking around the room and walking through, I see many of our friends from Baltimore here. Can I just see a show of hands? How many of you are Baltimore-based who are here? Wonderful. Well, good to see everyone, especially those of you from Baltimore, but good to see everyone. I'd like to say thank you also to Dr. Maya Rockymore, the head of Global Policy Solutions, who has been such an incredible thought partner in all of our work. Actually, many of the programs and ideas that I'll be discussing here, she has played a critical role in helping us to think through them and figure out how can we best do meaningful community engagement and implement these programs. So thank you for your action, your dedication to service, for everything that you're doing in policy in Baltimore and Maryland and across the country. Thank you, Dr. Rock. When Maya first invited me to speak with all of you today, I thought the timing is a little tight. As you can see, I am expecting a child at some point. But I said to the baby before I came, today is not the day. I gotta make it down to National Harbor. It's going to be my first child, so there's a lot that I don't know, but if there are any of you trained in OB or pediatric care, hopefully today is not gonna be the day to practice it. But I was very happy to be here and to speak with all of you at the Wealth and Health Equity Summit because, as Maya and Elise and others mentioned to me at the time, you all are on the front lines in Baltimore and DC and really all across the country in communities, and all of you have a commitment to serving the underserved. Whether it's in health, whether it's in economic development, I mean, all of you are deeply committed to these principles that we hold dear. So I'm really happy to be here, and what I want to do to start with actually is to tell you a story of one of my patients. Because for me, as a practicing emergency physician, this is what grounds me at the end of the day. So I want to tell you about Max, who is an 8-year-old. And Max, I got to know in the ER very well, which if you're an emergency physician and you know your patients very well, there's something a little bit not quite right about that, right? Why do you know your patients very well? Well, it's because I saw Max every week, basically, in the ER. And he would come in with virtually the same symptoms every time. He'd be coughing, he'd be short of breath, and he'd be wheezing. Now, he has asthma. And every time he came in to the ER, we as physicians and nurses knew what to do. We would listen to his lungs, we would give him an inhaler, sometimes give him a nebulizer treatment, sometimes steroids. We would review his medications and he'd get better. He'd go home, except that he'd be back. Sometimes we would ask the questions that we knew to be important to be asked. For example, we would ask about where he lives. Does somebody smoke at home? And we learned that he and his mother and his older sister were often without housing because his mother and his family were victims of intimate partner violence, domestic violence. They were often living with other relatives. Sometimes they were living in shelters where other people around them smoked. That was triggering Max's asthma. There were other times too, at some point, they actually got housing, but they got a row house where there were 2 other row houses around them, and those other 2 row houses were vacant. And so even though their house may have been fine in terms of allergens and smoke and other things, who knows what were the other things going on around them. And through that experience of getting to know Max, I also got to know his mother, who at the time was 23 years old and again had 2 kids, Max and his older sister. Now, for her, I learned about the many things that she was going through, including one day she came to tell me that she had gotten a job and she was so excited that she was now on the hotel cleaning staff, and she was really excited that she had this job. The next time that I saw her, she told me that she lost her job. And the reason was that she had put her uniform that day into a locker. And when she came back, the uniform was stolen. And then she talked about, she complained and said to her manager that the uniform was stolen. She was told that unless you can pay for the uniform, you can't come back to work. She didn't have the money to pay for the uniform and for her bus fare to get to work. So she lost her job. And it's in getting to know Max and her mother that I think it's important when we look at individuals. Sometimes people, including people in the ER who also treated Max and also got to know his mother, sometimes people look at these individuals that we're treating and we say, well, here are the choices that they made. Why is it that Max is always in the ER? Why can't his family figure out a better way to deal with his medical condition? Or people look at his mother and say, well, why can't she just get a job? We ask these questions and we assume that there is this choice that people are making, but I also think it's important for us as people committed to equity, to health, to wellness, we also need to look a lot deeper and recognize that choice is predicated on privilege. And so what I want to do today, because I can talk all day, and I'm sure all of you know many of these stories of Max and his mother, I don't just want to talk about the problems, because we can talk about the problems and the numbers all day. And in Baltimore, we have neighborhoods just a few miles apart where a child born today can expect to live 20 years less or 20 years more. 20 years, just depending on what zip code he or she happens to be born in. I mean, we know these disparities. Actually, I was thinking about showing slides today. I didn't, but I could have shown a slide that has a map of our city. And it will have different color codes and other things on it. And it actually almost doesn't matter what those color codes, what the legend says, because we know that these disparities are present in every community, in every city, in every way, that the same areas that suffer from poor health outcomes and poor life expectancy also have high infant mortality. They also have high cancer rates. They also have high violence. They also have high addiction. They also have high poverty. We almost don't need to see those numbers anymore, because when we look at only the problems, I think it makes it seem like the solutions are almost beyond us, like it's just too big. So what I want to do today is to not only admire the problems that we have, but I want to talk about solutions. And I want to talk about what are the things that we can do to change that narrative of choice being predicated on privilege. And I want to also for us to highlight what is working. Before I do that though, someone said to me once, and I think this also captures what many of us in this room probably believe, which is that when we look at a city like Baltimore or many of your cities, where we have that huge difference in life expectancy, we know that that cannot just be explained by the healthcare system alone, right? I mean, we have Johns Hopkins, we have University of Maryland, we have Mercy, Sinai, we have great institutions. People fly from all over the world to access our healthcare. It's not because we have bad healthcare that we have poor life expectancy. It's because of many other things, including the environment that we live in. What am I supposed to do when I see my patients coming in who have diabetes or heart disease or high blood pressure, and I say to them, please eat healthier foods? But they tell me I have to take 2 buses or walk 25 blocks. And by the way, that walk isn't exactly very safe. And by the way, if I go somewhere to get healthy foods, it's a Whole Foods and I can't afford the food. How hypocritical is that for me to say, well, it's your choice to eat healthier foods, when in my city, 1 in 12 white people live in a food desert compared to 1 in 3 African Americans live in a food desert without access to healthy fruits and vegetables. Again, can we really say that choice is predicated on, or can we really use that rhetoric of choice? But I heard someone say, and I think this again underscores our work, which is that the currency of inequality is years of life. And if we go further than that, then we know that the opposite of poverty is health. So the problem though is, if health is about everything, if we have to address poverty, if we have to address housing and transportation and all these other issues, where do we even begin? So I want to give you 3 ideas. The first idea, and what we are focused on in Baltimore through the lens of health, is that we have to start with our children. We have to start as early as possible by giving our children the best opportunities to succeed. So I want to tell you about what was going on in our city not that long ago. This is back in 2009. In 2009, Baltimore City had one of the worst infant mortality rates in the country. I mean, our babies were dying at the same rate as babies that were born in the middle of civil war in other countries. I mean, simply unacceptable in this time. I mean, 2009 was not very long ago. This is 8 years ago. Also, an African-American baby born in our city in 2009 was 5 times more likely to die than a white baby. Unacceptable outcomes, unacceptable disparities. We said as a city, this is something that is solvable. Other countries have done it, other cities have done it. This is something we can work together on. I mean, how can we be under the shadow of Johns Hopkins, this revered medical institution, and all these other hospitals, and we still have these extremely poor outcomes? Who are we as a society if we can't take care of our babies? So we said, we will fix this. We formed a collaborative with over 150 partners across our city, all of our hospitals, all of our clinics, neighborhood associations, faith leaders, community-based groups. Over 150 partners together, we said we can solve this. And as a result of home visiting programs, for example, we have nurses and social workers and community health workers do home visits. We teach the ABCs of safe sleep. We talk about breastfeeding. We do free crib deliveries to emphasize the importance of the ABCs of safe sleep. As a result of all of these efforts, within 7 years, within 8 years, we have cut the infant mortality across our city by nearly 40%. Which, 40% sounds like a lot, but in real numbers, this is what it means. It means that 50 babies that would have died in 2009 will not die now in 2017. And I think it's important for us to talk about this and to talk about these stories of success, because they're often, the narratives that are out there. They're these narratives of, well, if we, no matter how much money we put into our cities, nothing is going to happen. Or inner cities, look at all the things that are going wrong. I mean, we can't move we can't move the needle. We can't, even if we pour millions of dollars into it, nothing's going to change. Well, this is an example of how within actually a short period of time, we were able to really move the needle, change the outcomes, and ultimately it's about saving lives. So focus on and start with our children, number 1. Second idea, and I don't see anybody throwing food at me yet, but maybe this will come. Second idea is that we have to recognize that the choice that we have is predicated on privilege and power. So, I've been thinking a lot about this, and I should acknowledge also the Robert Wood Johnson Foundation for funding us today and allowing us to be here. I received the lobbying guidelines by the RWJ Foundation, so I know that I'm not supposed to lobby you on anything, and I'm not going to. I do want to say, though, that it's been challenging for me as a physician and a public health official in my role, because I'm an appointed official. I'm not supposed to be talking about politics, and certainly I would not want to be partisan. It's hard for us, though, for me, and I think for any of us in healthcare, to not have an opinion about healthcare legislation, or to not think about, it's not a question of lobbying for it, it's a question of analyzing what is going to be the impact of these legislation on our most vulnerable residents, on our populations here in our city. And so this is the frame, that this is not lobbying, I'm not asking you to do anything, I'm just sharing with you my own experience, as well as my experience as being in charge of our healthcare system in Baltimore. So I've been thinking a lot about this and the debates around the ACA in relation to my own healthcare. I feel very lucky that I have really good health insurance. I'm very lucky that I do, because early in my pregnancy, and I didn't know this, I'm otherwise a pretty healthy person, but early in my pregnancy, I found out that I have a high-risk pregnancy. And my doctor asked me to come in every 2 weeks for monitoring, for ultrasound and blood work and other types of routine monitoring. I never hesitated before saying yes, because I think, like all expecting mothers, I want to do what's best for my child. And I want to make the best choices for my child. I never thought about coming in. I mean, I made regular appointments, made sure that I go to my appointments, but I wonder about what are the choices I would have to make. Let's say if I didn't have insurance, and every time I thought about, well, this ultrasound will cost me $500. Do I pay for this ultrasound to help this child be healthy, or do I pay for rent for my family? Or this blood work, I got it done 2 weeks ago. Maybe I can just skip this $120 blood work this week and hope that it's going to be okay, because I don't want to not pay for food for everybody else. I mean, these are the choices that I'm fortunate I don't have to make. And we know that it's not just a matter of people making choices for right now. It's also about actual outcomes too. Studies have shown that women who do not get prenatal care or get inadequate prenatal care are 5 times more likely to have children who die than women who do get prenatal care. And yet in my city, in Baltimore, more than half of our pregnant women, which is 9,000 pregnant women a year, by the way, it's a lot, more than half of our pregnant women depend on Medicaid. If Medicaid were to be cut, what are going to be the choices that people have to make? What are the trade-offs that we're going to have to make people, that we're going to have? Again, there is this rhetoric of choice. And you know, I'm sure we all have heard individuals say, well, women choose to be pregnant, and so what if there are health insurance plans that don't cover maternity care, right? Why should I have to pay for other people to get maternity coverage when it's a choice? Well, we also know from data, from research, that half of all pregnancies are unintended pregnancies. And in fact, for us to really have choice, we also have to have other services available, like contraceptive coverage, which, by the way, has saved $1.4 billion a year as a result of mandated coverage. Part of women's health care is not just about contraceptive care, it's also about well women exams, about breastfeeding, screening for cervical cancer, screening for breast cancer, screening for domestic violence, treatment of sexually transmitted diseases, HIV. If Medicaid were gutted, or if women's health care is no longer covered as part of essential health benefits, which, by the way, why is it called essential health benefits? Because it's actually essential. Maternity care. If that were to happen, then what kind of choices are we going to have? We know that, based on many studies, that education alone is not enough. That we can't just have policies saying you should be educated unless we also have the services there so that people have the options. It's easy to talk about choice when you have privilege. And ultimately for us, it's important to look at who is at the table, who is even there to make the choices. And that's why the second principle that we follow is to recognize that the choice is predicated on privilege and power, and it's our job as the frontline workers who hear the stories of our patients, who hear the stories of our community members, to say, this is the impact that it's going to have on our community. This is not political, right? It's not lobbying to say, you should, as a result, do this. But for me in Baltimore, I cannot do my job if I don't point out that 85,000 of our children depend on Medicaid and Children's Health Insurance Program, right? I cannot do my job if I don't say that 2/3 of our older adults who depend, or 2/3 of our older adults with nursing home care depend on Medicaid. I mean, that's what we see every day. We may see the trade-offs also in our patients. I remember having this patient whom, this was before the ACA, who I met in the ER, who could not get care, who could not afford insurance because she had a pre-existing condition, diabetes. she could not get insurance to treat her diabetes on a regular basis. But the time that she could get her diabetes treated was after she had to have her leg amputated because of an infection. Now, what kind of system are we in? What kind of perverse system are we in when that's what we incentivize, right? We say, you can get really sick and we'll treat you then. It's actually cheaper to treat you beforehand, but we're not going to do that. That's also our job, to talk about these issues and how they impact our communities, recognizing that the rhetoric of choice just is not enough. All right, my third idea, no food thrown yet, but there could be still to come. My third idea is that it's our responsibility to call out the problems that we see. Whatever problems that we see in our communities, and there may be a lot of them. For example, about earnings. I know you all talk a lot about this, but the fact that women earn 79 cents to the dollar, women of color earn 63 cents to the dollar. I mean, what does that mean in terms of our value? What does that mean in terms of our employment and the safety net and security that we want to build for ourselves and our families? Paid sick leave. So I know we're all eating here, maybe this is not the best time to mention this, but the CDC came out with a study, found that as a result of us not having paid sick leave and paid maternity leave and others as a country, that for food service workers, 2/3 of food service workers go to work while they're actively ill. And it's not about, I'm sure these individuals don't want to go to work when they're ill, they're not trying to infect people, but what are the options that we have when it's also about providing for our families? Or lack of affordable childcare. You know, we like to say that we have core values in this country of work and family, and religion, and whatever other core values, but we like to say, everybody will say we believe in work and we believe in family, but what does that say about our core values when we don't have paid maternity, paternity leave, and when we don't have affordable childcare options available? What is the message that we're sending? We need to call out these problems and more. And I want to add one more too, because Elise had mentioned in her introduction about our work around treating addiction. We're very proud of, in Baltimore City, to have launched one of the most aggressive overdose prevention programs in the country. So people dying from opioid overdose, in our city, there are astronomical numbers. I mean, there are more people dying from overdose in our city than dying from homicide. Every day in our city, 2 people die from overdose. I mean, this is a huge issue. These are our fellow community members. In the ER, I know that there is an antidote to opioid overdose that I've given to hundreds of patients, naloxone or Narcan. And for me, it's unconscionable that if somebody's life can be saved by my giving someone this medication, it's my job to give it to them and to make this as widely available as I can. And so we got the law changed, and I issued a blanket prescription. So for those of you providers out there, kind of scary to write your signature on 620,000 prescriptions. But we did that because it's about saving lives. And it's about making sure that everyone has the ability to save a life. So I even have an updated number from what you heard earlier, which is that since 2015, everyday residents who are carrying Narcan with them have saved the lives of over 1,000 of our fellow residents in our city. But I'll tell you, though, that this is not without a fight and not without a battle every day, because I hear people saying, well, at the same time, we are saving lives. People are saying, but why are you making that medication available? Aren't you just going to make more people use drugs? But I would say, if we recognize that addiction is a disease, which every medical and scientific community does, would you ever say to somebody who's dying from a peanut allergy, I'm sorry, I'm not going to give you an EpiPen because it might make you eat more peanuts next time? Right? Or we would never hear someone say to a patient with diabetes, can't you just get off of your insulin? You've been on insulin for a month. Shouldn't you just be sober and clean off of your insulin? But we would never say that, and yet we tell people with the disease of addiction all the time these horrible, stigmatizing comments. We don't want them to live in our communities. We don't want to see them. We pretend it doesn't exist, when actually it's in every community, in every city across the country. We have to call out that problem. But there's one more on top of this that I want to add too. Our governor in Maryland, Governor Hogan, declared a state of emergency around opioid overdose, not too long ago, a couple months ago. Now I remember that I was at a community meeting where someone stood up and said, I'm glad that the governor declared a state of emergency, but there has been a state of emergency around addiction my entire life. And I think it's something that needs to be said, that when it was poor minorities in the inner cities who are dying, then we labeled addiction as a choice. We said, if you made this choice, then somehow it's your fault. It's a moral failing. If you end up in jail, you end up dead, it's your fault. And now that addiction has spread to other areas, and now we're seeing the face of addiction also being white and wealthy and suburban and rural, now we're saying addiction is a disease. You can check yourself into a clinic and get treated. I'm not saying that addiction isn't a disease. Obviously we need to treat it as the disease that it is, and we need a lot more funding for it. But I also think that we need to be honest with ourselves and recognize this is where we came from. This is the history of inequity. This is the history of disparities. This is the history of structural racism that have gotten us to where we are. And also, I hope that other people will join me to say that now that we recognize finally that addiction is a disease, we owe an apology to generations of Black and brown and minority people who have been incarcerated because of it. So calling out the problems that we see. None of these things that we talk about today, whether it's with starting with our children or talking about privilege and all these things, I don't think any of these things are easy. But I would say too that advocacy isn't easy, that social justice isn't easy, and that none of the work that we do is easy. But there's also no more important time than now for all of us to step up and into the arena. And we look at our children who depend on us, and I'm now going to quote Congressman Elijah Cummings, one of my heroes, my local, my congressman, and someone you all may know very well. Now, Congressman Cummings talks about the generations of children who are yet unborn, as these are not just things that we're fighting for. These are not just issues that we're aiming to talk about. These are people. These are our communities yet unborn, our future that we're fighting for. And these are the individuals who depend on us to do the hard things and to do the right things. So I want to end today with a quote by another one of my heroes, Congressman John Lewis, civil rights leader and a person who is never afraid to speak truth to power. And he talks about how there is bad trouble and there is good trouble. And good trouble is when you stand up to injustice. And so I urge for all of us here, all of us as social justice leaders, as health leaders, that this is our time, that we must lift up what is working, that we must start with our children. We must start with the pervasive narrative that exists and call out the problems that we see. That we must level the playing field of inequality and talk about how it's not acceptable that the opposite of poverty is health. And we must stand up to injustice and lead with urgency, compassion, and action. And every step along the way, I pledge to join you, march with you, and fight with you. Thank you.